بعد اذن
لا لا،
حضرتك.
ازاي؟ تحت امرك.
طيب. طب بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا ونبينا محمد صلى الله عليه وسلم. النهارده الزوم رقم 82، الأسبوع 82 على التوالي لسيمينار اسم الجراحة في طب أسوان. والحقيقة إن النهارده يوم مميز جدا، معانا أحد الأساتذة الكبار في جراحة الأطفال في مصر، أستاذنا الدكتور أسامة النجار، أستاذ جراحة الأطفال طب عين شمس. هيكلمنا عن عن فيري هوت توبيك، فيري امبورتنت توبيك محتاج ان احنا كلنا ناخد بالنا منه، نشوف ازاي نتعامل معاه، ازاي نواجهه، ازاي نعمل اكيوريت دايجنوزس، ازاي نوصل لديسيجن ميكنج صح. هو ديودينو بانكرياتيك اند اكسترا هيباتيك بيلياري تروماتيك انجري ان تشيلدرن. وانا لو قلت كلام كتير عن دكتور اسامه مش هقدر اوفيه حقه. احنا بنشكره ان هو يعني خد جزء من وقته علشان يساعد فيه كل اللي موجودين من النواب والمدرسين المساعدين في اسم الجراحه في طب اسوان، وكل الزملاء الحضور معانا من زماله الجراحه في اليمن، وزماله الجراحه في ليبيا، وزماله الجراحه في الكويت، وبعض الزملاء في محافظات مصر المختلفه بيحضروا معانا دايما اونلاين عشان يعني يسمعوا ويتعلموا من اساتذتهم. ويا رب يكون السيمينار مفيد للجميع ان شاء الله، ويبقى له اثر في زياده الكونتينوس ميديكال اديوكيشن لزمايلنا، وكمان يبقى له ريفليكشن على العيان، بان يبقى فيه قرارات صحيحه بتتاخد للعيان. انا مش هطول يا فندم عشان حضرتك تبتدي، ومتشكرين المره واثنين وثلاثه على وجود قامه حضرتك معانا في سيمينار اسم الجراحه في طب اسوان. اتفضل يا فندم.
شكرا جزيلا دكتور ابراهيم. السلام عليكم ورحمه الله وبركاته، جميع الزملاء في اسوان وعلى الزوم في اللي بيحضروا معانا الميتنج دون. سعيد جدا بلقائي معاكم، وارجو ان شاء الله ان انا ابقى اكون اضافه ومفيد لحضراتكم. انا حاولت اخترت الموضوع دون. طبعا هو because of it is a rare disease or a rare occurrence or incident. ولكن نيكست بي نيكست. اتفضل يا بيه نيكست. ولكن لانه هو رير، فالكلام فيه مش كتير. وانتوا تحبوا حضراتكم يعني فرانكو عرب كده ولا انجليش بس ولا ايه؟
يعني اللي حضرتك شايفه معانا كمان دكتور محمد نادر هيمودريت مع حضرتك ان شاء الله النهارده. اللي حضرتك حابب تعمل فيه ديسكشن، او لو حضرتك حابب تو كلاريفاي
طبعا
اني
طبعا. المهم انتوا طيب عندكم التايم لاين قد ايه بقى؟
لا، مفتوح.
طيب ماشي.
اتفضل يا فندم.
هنبدأ من الساعة 10، بس حضرتك الافتتاح الساعة 12.
لا ان شاء الله قبل كده نخلص ان شاء الله.
ان شاء الله يا فندم.
ماشي. طيب انا في in the beginning I would like to start with giving you what's called for me a conceptual framework of the problem of pancreatico duodenal and extrahepatic biliary injuries in children. In fact, most of the data and the concepts here in pediatric cases are derived from the management of the adult cases. Except some differences between the adult as an adult and the pediatric patient, because always we are saying that the child is not a small adult. Although a lot of the principles are derived from the adult literature, because this was one unit. I mean, the trauma management was not making a distinction between the adult and pediatrics, but because of the peculiarities in the pediatric patients, so there is a need for special considerations in the pediatric age groups. What I mean by the conceptual framework, I will try to summarize the problem. In fact, the injury in this area, it can occur either as a blunt abdominal trauma or a penetrating abdominal trauma. In fact, the most common is لا خلينا في لسه حضرتك. انا يعني لما هبدا يعني اغير هقول لحضرتك. As we said, this is a rare tumor. It's a rare problem. And if it is rare in adults, it is more rare in children. And if we think about the commonest mechanism of injury in adult, it will be the penetrating type of trauma, while in children's, the most common mechanism of injury is a blunt abdominal trauma, as we will see. In fact, these lesions are not a direct cause of mortality for these patients. I mean, just because you have a duodenal injury or pancreatic or extrahepatic biliary radicals injury does not translate in a mortality or death for these patients. Usually, the death in these patients or in this setting occurs because of associated injuries. And so it's very important when we have a case of abdominal trauma and we are suspecting either of these lesions, we have as well to suspect that this patient had associated lesions, especially if the hemodynamic situation of this patient is unstable or is not responding to the resuscitative measures that we give. And we are describing these lesions as well, or injury as well as transitional injury. What I mean by transition injury, that means that these lesions are, if you are faced with them, you are not going to treat them in the emergency situation only. Sometimes you are left with sequelae of these trauma or these injuries that you need to consider later on. And so it is not only the emergency surgeons or emergency doctor the one who is going to deal with these lesions, but as well involvement of the hepatobiliary and pancreatic surgeons is important because of the sequelae of these lesions. So we describe them as transitional injury. In fact, if we want to summarize what are the factors that will drive our management algorithm in these patients, there are three elements that will drive this management paradigm or management strategy. The first is, and for the most, is the hemodynamic status of the patient. The second is, how does these lesions clinically present? And number three, the what's called organ injury grade. The societies for trauma surgeons had classified the injury for in these areas, the duodenal, the pancreas, and the extrahepatic biliary systems, into grades and scales. Of course, as the grade is increasing from 1 to 2 to 3 to 4 to 5, the severity of the injury increase as well as the complexity of the injury increase. So depending on these three factors, our decision in these cases will depend. Next. A very evolving and important concept in management of trauma, and this is maybe the one area that the pediatric surgery or trauma in children had influenced the treatment of trauma in an adult patients, which is the concept of non-operative management of these traumatic injury. As you know, most of you or all of you know that the non-operative treatment of a solid organ injuries like the liver and the spleen in children is now the standard of care. And I think as well now in adults, the non-operative treatment, conservative treatment of patients with liver injury and splenic injury are going on the same route. That is the non-operative management strategy to be applied to these cases. In fact, the non-operative management or the paradigm will not be satisfied except if we don't have a good interventional radiologist and as well an endoscopic service. This is very important parameters or prerequisites to adopt a non-operative treatment. And in addition, of course, to a blood transfusion service that will help us to observe and monitor our patients and help us to continue the non-operative treatment for these patients. So if you don't have blood transfusions, if you don't have a good interventional radiologist, if you don't have an endoscopic service, so it is very hard to advocate the non-operative management strategy for these lesions. And I will explain in the coming sections what I mean by that. Next, please. In the operative management of these lesions, there are a general principle that should be applied. First, the damage control surgery, or the principle of damage control surgery. If you are faced with trauma patients, abdominal trauma patients, with suspected pancreatic or duodenal injuries, and you go and do an operation for them, when you open these patients, you have to remember that the time is a crucial factor in managing and in the life for these patients. You have to save the life of the patients and not the organs that
ده
these patients
صعب.
have.
طب إيه يا عم اللي يخليه يعني؟
So, so the damage control surgery principles should be applied, and we will explain how to apply this to the management of these trauma. And of course, sometimes you as a surgeon want to solve all the problems of the patients in one shot. This is not applicable for managing trauma cases. Staged operation in the emergency situation or settings is the standard of care. And afterwards, you have the concept of what's called second look operation. After the damage control surgery, you can do a second look operation, and then you can stage the operation that you want to do, as we will see. And a late reconstructive, if you want a highly skilled reconstructive procedures, you should do them in a second stage or in a delayed way. Next. Of course, the injury of the duodenum with its nearby association with the pancreatic ducts and the bile ducts carries a sequelae later on, or a long-term sequelae like strictures, like obstructive jaundice, like pancreatitis, recurrent and chronic pancreatitis, like endocrine and exocrine dysfunction if we do a resection to the pancreas. All these are late sequelae and complications that the victims of these lesions or these trauma or these injuries are liable to. And so we have to always consider that these patients, they should be followed up for a long period of time to avoid the sequelae that will need interventions later on in these patients. So the concept of a long-term follow-up for this trauma is very important. Next. In fact, the most important concept in managing these cases is the definition of the hemodynamic stability in the patient. Because as we'll see later on, that all your decisions, the diagnostic decisions and the management decisions or the treatment decision that you are going to take depends on this definition. Is your patient stable or not? If your patient is not stable, he will take a certain track. And if the patient is unstable, definitely these patients will need an immediate and emergency interventions. He will not wait too much investigations that you can do at leisure, as well as the concept of the non-operative management is violated and is not applicable in these conditions. So the most important the question that you have to answer if you have a patient with this trauma and trauma in general, is this patient hemodynamically stable or not? Of course, as you know, the hemodynamic stability definitions depend on the vital signs like the blood pressure, systolic blood pressures, like the heart rates, as well as other manifestations like the capillary refill, the level of sensorium or the level of consciousness, the skin, is it pale or not, and the basic SAS, this patient is acidotic or not, as well as the urine production, is this patient is producing urine or not. All these factors are measures or a metrics of the shock status, that your patient is in shock or not. Of course, if your patient is in shock, you have to start resuscitative measures for him, and then you will have one of two responses for you in your patients. If your patient is initially unstable, and in the pediatric age group, if you give for them crystalloids, 3 boluses of crystalloids of 20 ml per kg, and the patient starts his heart rate to stabilize, starts his skin to be warm, starts to bring the capillary refills, okay, and the conscious level is to improve, then you say that this is a responding patient, and you can consider him for the non-operative treatments that we will describe, or the doing more investigations, and not to take these patients to the theater. A problem in the metrics of shock in children is that the blood pressure of the child will not change, it will not decrease except very late in the shock states. So depending on the blood pressure, systolic blood pressures, to determine whether this patient, the pediatric or the child, is stable or not is very deceiving in the children's. So we need to have a more sensitive measures in children's to know whether they are stable or not. One of these is what's called the shock index. Of course, shock index is used in the adult situation as well, and the shock index is derived by dividing the heart rate over the systolic blood pressure. And there are endpoints that determines the patients who need further interventions, or need ICU or blood transfusions. I mean, the shock index in trauma patients is a very important parameter that you can use and can help you to triage your patients, to understand the severity of the problem that you have, as well as it can direct you to whether this patient can be managed in the emergency room, or he should be shifted to the ICU, he needs blood transfusion or not, and even if he is not responding to your resuscitate measures, he may be in need to go to the theater. So the shock index is an important matrix that you should know, and it is a simple calculation. Just measure the systolic blood pressure, that is the minimum systolic blood pressures, and the maximum heart rates. If you divide them, you will have a ratio. That ratio you can use to do all the predictions that I mentioned now. In cases of the pediatric patients as well, we have to modify this shock index. So we have what's called the shock index pediatric age adjusted, because the normality or the normal blood pressure and the normal heart rates is different according to the age of the patient. I mean, the normal blood pressure and heart rates in a child of 6 years is not the same like a child of 6 months. So a need for having a modified parameter or metrics, which is the shock index pediatric age adjusted, and it's very helpful to determine the hemodynamic stability of the patients, as well as predict the need for further intervention. This is very important concept, the hemodynamic instability in children as well as in adults. Next. Next, please. The classification and grading of the grading of injury of the solid organs that we are dealing with. We have two main classification system: the AAST system, which is the American Association of Surgeons of Trauma, and the WSES system. The difference between the AAST and the WSES is that the WSES, considering the grade of the injury in the AST, layer 1, 2, 3, 4, plus or in addition to the hemodynamic stability. That means that the hemodynamic stability here is the main issue in putting the patients in a mild, moderate, or severe category in the WSES, in addition to the anatomical classification, because AAST system is an anatomical classification that describes the grades of injury in the different organs in the body. I will show you some examples in the next slides. Next, please. So this is very important. Next slide, please. Next slide. Yes. This is, for example, the pancreatic injury scales. It is from 1 to 5. And as you see, as you go from 1 to 5, you go from a less severe to a more severe forms. Next, please. طبعا يعني كل الحاجات دي موجودة يعني. And this is a graphic presentations of the different grades of the grading system that I described: 1, 2, 3, 4, and 5. Next. And this is as well the duodenal injury. And here, to give you the important item, the important elements in these grading systems that you should remember is, in the duodenal injury scale, the question that you should answer is the duodenum perforated or not? Whatever the descriptions, there is hematoma, there is contusion, there is 50%, less than 50%, more than 50%. So the main question is the duodenum perforated or not? In the pancreatic, can you go a slide before, please? In the pancreatic grading system, the main question that you should remember is the main pancreatic duct affected or not? Remember that we have the main pancreatic duct and branches of the pancreatic duct. The most important and crucial information and question you should answer in a patient with a suspected pancreatic injury is the main pancreatic duct is affected or not. Because these two factors, in addition to the hemodynamic stability, will guide you in the further diagnostic modalities that you need to use, or the management and treatment for these patients. Are you going to take the patients to the theater, or are you going to deal with the patients in a non-operative way, or the NUM strategy? And are you in need for endoscopic service to help you to manage these patients, or are you need for an intervention radiology to do angioembolization, to do drainage, to do whatever procedures that can help you to deal with the injury without taking the patient to the theater? So please remember, in all what are we going to discuss now, the two questions in the duodenum is perforation, the pancreatic injury, the main pancreatic duct is intact or affected. Next. Next, please. Next, please. And this will as well the extrahepatic biliary injury. In fact, this area of extrahepatic biliary radical system, the head of the pancreas and the duodenum are considered as what's called the surgical soul. In fact, this very little area in size, carrying a very complicated relations and complicated anatomy. And if you are unfortunate surgeons, you will face these types of injuries. The time for managing these cases, when you operate on these cases, or if you have a case that presented in this way, it takes all your senses and all your thinking, because it is considered as what's called the surgical soul. Very important to understand these three elements, or the three areas of anatomy, are interrelated, and injuries of one may be associated with an injury of the other one. And so your rule as a surgeon is to differentiate and to know the injury and the associated injuries. So your decisions as well depends on the answer of this question. Do we have an isolated injury of this one of these areas, or we have an associated injuries of this area, in addition to other associated injuries like other visceral injuries, like big vessels or large vessels injuries? I mean, this is very important. When you think in this area, think it at the surgical soul, and think of it as interrelated and associated together. Next. Of course, the clinical presentation for these lesions is different. And in fact, because of its retroperitoneal position, you may have a major injury of these structures and these organs without too much evident signs on the abdomen. And most of these cases as well may not show themselves in the early phases of the injury or the trauma presentation for these patients. What I mean, the patients may have an injury. Of course, as you know, when you take history from any patients about the trauma mechanism, is very important, because knowing the trauma mechanism or the mechanism of trauma, you can anticipate the type of injury, as well as you can anticipate the degree and the severity of injury that you may have according to this mechanism of injury. These lesions, in fact, and unfortunately, may present with a vague and non-specific signs and symptoms in the early phases of the trauma accidents or trauma incidents. And so you have, what I want to say, that you have to have a high grade of suspicion to diagnose or to suspect the presence of these lesions in any traumatic patients who presented with certain types of or mechanism of injuries. In children, the most common type is the handlebar injury. For example, a child is driving a bicycle and then he had a trauma and the handlebar is hitting his epigastrium, and the patient is coming to you, hemodynamically stable, no too much signs and symptoms on the abdomen, but you have to assess and to suspect the presence of these lesions, because, as I said, they are present in a very secure and very deep locations in the retroperitoneum. So you may not have a peritoneal signs like peritonitis or peritonism or free air in the abdomen that can point for you for the occurrence of these lesions. So a high rate of suspicion for the occurrence of these lesions is very important. Next. Next, please. This is a slide showing why in children's the handlebar will lead to injury to the pancreas, because as you see, the pancreas is in direct relationship to the vertebral column, and with compression of the handlebar to the pancreatic area or to the epigastrium, the pancreas and the duodenum may be crushed in between the handlebar and the spine, and this leads to the occurrence of injury of the pancreas or the duodenum. Yes. Next. Next, please. Okay. So how can we diagnose if the clinical presentation or the clinical symptoms and signs are not specific in this case? So how can we diagnose these injuries or suspect them in patients presented for us in the emergency room? We have laboratory investigations. The most important of these are the amylase and lipase level. But you have to remember that in the first 3 to 6 hours, the amylase and lipase level, even with a grade 5 pancreatic injury, may not be elevated. So a serial and repeated measurements of the amylase and lipase level, as you know, the lipase is more sensitive, is more specific enzyme that indicates the presence of a pancreatic injury, while the amylase can be elevated, for example, in skeletal injuries or even in a visceral injury, intestinal or colonic injuries, the amylase level can be increased. So the increased level of the lipase, especially after from 3 to 6 hours, or if you repeated, so you have to repeat the amylase and lipase levels. If the initial assessment, it was normal or within normal, you should not say that this patient, or you should not exclude the presence of pancreatic injuries, because as I said, you have to measure them after 6 hours of the trauma, the incident of trauma, and by repeating them, you will see a trend of increasing level of these enzymes, specifically the lipase enzyme, and these can increase the suspicion for the presence of a pancreatic injury. And the presence of high level of lipase and amylase or an increasing level of lipase and amylase necessitate that you have to exclude the presence of a pancreatic or a duodenal injury. The first and the first investigations, the non-invasive, the portable ultrasounds, and all of you know about the fast ultrasound that you do in the emergency room, where by the ultrasounds, the conventional ultrasounds, you can identify the presence of fluid collections in the area of the duodenum and the pancreas. And if you have this, so fast ultrasound is an important measure or is an important tool that you should use and you should have in the emergency room, because as well it will support the suspicion that there is a pancreatic or duodenal injuries if you found a fluid collections in the epigastrium. So this is very important measure and important tool. And as well, of course, the use of the official or the formal ultrasound examinations to examine all the parts of the body to identify the presence of injury or the solid organ injuries is very important way, non-invasive way for diagnosing or for assessment of the traumatic patients. In fact, there is a new modality or a new type of the ultrasound, which is a contrast enhanced ultrasound. Actually, the type of contrast in the cases of the ultrasound is not like urographene or something, but they are using now micro bubbles, air or gas, that is they are putting in a saline or a liquid solutions and inject this tracer or this contrast intravenously, and this will concentrate in the vascular phases or the arterial and venous phases, that's or the arterial and venous circulation supplying the organs, and this will enhance the quality of the images that you can detect lesions in the pancreas, especially by using this modality of treatment. Is very important and very promising. That can help us to diagnose problems and pathologies in different organs, especially liver, spleen, and the pancreas. But in fact, their value in the emergency situation is less than the other types of modalities that we are going to talk about. But in the stable patient with a suspected injury or lesions in the pancreas, the contrast enhanced ultrasounds may be an important tool. The gold standard for diagnosing, or in fact, for suspecting duodenal perforation and diagnosing pancreatic injuries, although not the main pancreatic duct disruption, is the CT with IV contrast. So CT with IV contrast should be an essential tool that you should use, of course, in the stabilized patient or in stable patients, to confirm the diagnosis of suspected duodenal, pancreatic, or extrahepatic biliary radicals injuries. You should use this CT scan, not the plain one, but the CT scan with the IV contrast, and as well as in the new equipments of CT nowadays in the modern era, they are, or you should use what's called the pancreatic phase. So you have to use the multi-detector CT scans in a multi-phases. We have, as you know, the triphasic CT scan, the arterial, the venous, and the portal. And as well, there is an additional phase which is called the pancreatic phase. And using the CT scan of with IV contrast of a high quality equipment, I mean 64 multi-detector CT scans or more, in the pancreatic phase, which is aquastation, the pancreas, it takes the contrast in the first 40 and 60 seconds of injections. By doing or using the CT with IV contrast and the pancreatic phase, the possibility of identifying injuries in the pancreas, and maybe main pancreatic duct injuries is increasing. So using the CT with IV contrast in the pancreatic phase is very important, as well as it depends on your setting, if you have a recent machine for CT scan or not. If you don't have, of course, the CT scan will not be efficient or enough for you to have the full extent or spectrum of lesions, especially in the duodenum and the pancreas. The question is, does adding oral contrast with the CT, with the IV contrast, increase the performance of this study to diagnose duodenal perforations in the emergency setting? The answer is no. So it is not necessarily, because you may not increase the sensitivity and the specificity, or in general, the accuracy of these diagnostic tests to identify duodenal perforation. You may have duodenal perforations and it may not be revealed, even if you used an oral contrast study with the CT scan with the IV contrast. And I stress that it depends on the type and the model of your CT scan, the results can be. Okay? So we have to understand the limitation of our setting. We should not generalize what we are read in books, because sometimes somebody will say to you, the evidence-based medicine say the CT scan with IV contrast is 100% sensitive or specific in diagnosing pancreatic injuries. This may not be the situation, because sometimes you have to have a very recent CT scan, because it depends on how many multi-detector slices and timing acquisitions you have in your CT scan, and if you are using the pancreatic phase or not. All these ancillary measures is important to understand the value and the limitations of the investigation tools that you have. يعني اقصد ان احنا ما نحملش انفسنا اكثر من طاقتها. لازم نفهم الليميتيشنز بتاعه السيتنج بتاعتنا ايه. مش كل اللي بيتقال في الكتاب نقدر نطبقه في السيتنج بتاعتنا. تمام كده؟ طيب ما هو الناس تقول طيب يا دكتور اسامه، طب ما نعمل اورال plain x-ray with an oral contrast اللي هو barium swallow and meal or gastrografin swallow and meal, so we can diagnose the occurrence of extravasation, and so we diagnose the duodenal perforation زي ما انت بتقول. الحقيقه the plain x-ray with even with oral contrast as well is not doing well, is not of high sensitivity or specificity to identify the duodenal perforation. So it is not a mandatory, or it is not an important tool for you if you're suspecting lesions in this area. Next, please. This slide, the gray scale is the normal or the conventional ultrasound, while the brown one is what I mean by the contrast-enhanced ultrasound. When you inject an IV contrast, as you see, the head arrows points to the body of the pancreas, which is shown as an edematous structure after we used the contrast enhanced ultrasound. This is just an example, or I found it very interesting to introduce this tool of investigation, or this radiological equipment that carries a future it shows a promising future inshallah for diagnosing different pathologies, not only the traumatic injuries in this area. Next, please. Another example, you can see the difference in the visibility of the lesions on the brown, on the right side, the brown image, and the gray scale image, and compare it with the CT scan. On the left, you'll see a gray scale ultrasound, conventional. On the right is the contrast enhanced, and down, and the C is the CT with IV contrast pictures of the same lesions in the pancreas. And you can see that the ultrasound, the contrast enhanced, increases the utility of the ultrasound machine to identify or specify the lesions or the pathology in this area. Next, please. The next slides are, next please, next please. The next slides are examples of different grades of injuries, pancreatic injuries and duodenal injuries as seen by the CT scan. So I think we have to, next please, next please. يعني البرزنتيشن مع حضراتكم تقدروا تبصوا على الحاجات وتقدروا تشوفوا ال different pictures and different images of the different grades of injury in the pancreas and the duodenum. Next please. يعني انا عايز اوصل للاوبريشن لان هي مهمه. Next please. This is grade 4 pancreatic injury. This is grade 1 duodenal injury. Grade 2. لا 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 خلينا نرجع ورا كده سنه كمان. لا نرجع تاني كمان يا دكتور. كمان واحده، كمان سلايد. لا طيب بص، اللي هو السلايد دي اللي هي فيها الجول بلادر باينه قوي دي. دي لا، ننزل تحت يا دكتور. يعني اطلع فوق سوري. يعني next slide. next. ايوه دي بس هي دي MRCP. لا مش دي، انت ليه طالع بقى؟ بص يا دكتورنا العزيز، بص دي اللي قبليها بقى. ايوه دي واضحه دي. This is an MRCP. This is a coronal view of an MRCP. هنا عايزين نقول ايه بقى؟ ان a non-invasive and more sensitive way of identifying the situation or the status of the main pancreatic duct in the trauma settings is the MRCP. So if you are suspecting that your patient or you want to have this very important information قلت لكم عليها اللي هي is the main pancreatic duct is affected or not, so you have to ask for MRCP. As you see in these pictures, it shows a transected main pancreatic duct with extravasation of the dye in this MRCP picture. So MRCP is a very sensitive and non-invasive mean to diagnose the presence of or the situation or the status of the main pancreatic duct injury. Next, please. This is another example of a transected or a main pancreatic duct that is communicating with a fluid collection. And from the general surgery, that's the pancreatic fluid collections is a very important terminology and very important concept, especially in acute pancreatitis and in cases of chronic pancreatitis, the pseudopancreatitis, the walled-off pancreatic necrosis. This is very important terminology, and there is what's called the Atlanta classifications for the peripancreatic fluids, and it is a very essential concept and terminology managing problems in the pancreas. Yani the one of you who is interested in the pancreatic surgery will appreciate what I'm saying about the peripancreatic fluids classifications and its importance in management of different pathologies in the pancreas. Next, please. These are examples of the gallbladder classification. The gallbladder is the one with the black arrowhead. As you see, there is a very gallbladder fluid, and with as well as the wall of the gallbladder there is a discontinuity of the enhancement of the wall of this gallbladder, and this is a sign of gallbladder laceration that can occur in cases of extrahepatic biliary radicals injuries. Next. Yes, this is another type of investigations that sometimes we may be in need of, which is the HIDA scan. I am sure that all of you know the nuclear medicine HIDA scan type of investigation, where it is very essential for you to know whether the biliary radicals are leaking or not. So if you are suspecting that there is a bile duct injury, and this bile duct injury is not shown by the MRCP, you can do what's called the HIDA scan. It's a nuclear medicine way of investigations, and leakage of the dye outside the main pancreatic, main biliary radicals indicate that the presence of injury in this area, and it can point to the presence of injury and even classify the degree of injury in cases of bile duct injuries. So HIDA scan is an important investigation to identify the presence of leakage in cases of suspected bile duct injuries. But of course, the HIDA scan, because it takes a long time, it's a long time investigation. It needs a long time, so it is not suitable for cases of emergency. But if you have a stabilized patient and you suspected that he developed biliary collections, or you suspected the presence of bile duct injuries, HIDA scan and of course ERCP is very important investigations that can help you identify these lesions and assess their severities. Next, please. And of course, ERCP is a very important modality, and that's what I meant by the presence of an endoscopic service and people who can do ERCP for patients, even in the very hot traumatic cases, is very important. ERCP is an important modality that can help you to identify and stratify the type of injury in the pancreatic duct. And it is not only a diagnostic tool and classifying tools, but as well, you can use the ERCP stenting as a mean for managing cases of pancreatic, especially of cases of pancreatic injury, either in two forms, either to drain the papilla or to drain the pancreatic ducts, or to stent, cross-stenting the disrupted or transected main pancreatic ducts. In fact, this is available and possible and feasible in the adult populations. In the pediatric populations, because of the miniature of the size and the need for small-sized endoscopes and small-sized stents, the value of ERCP as a draining method of the pancreas in cases of pancreatic duct injury, or stenting and bridging the pancreatic duct lesions, is less of value in cases of pediatric cases or pediatric trauma. But it is of a paramount importance in cases of adult trauma. Next, please. These two slides can give you a hint about what we mean by using the ERCP and stents as a drainage. We can drain the common bile ducts or the pancreatic ducts, or if we have an injury to the pancreatic duct, we can bridge the injured pancreatic ducts, and this can help to avoid operations in some cases or in some scenarios of pancreatic injuries if you have the skilled ERCP personnel and the availability of the suitable stents that can be used in managing these cases. Next. Next, please. Another graphic presentation of the. So, what are the other modalities or ways or tools, in addition to the CT scan that we mentioned, to diagnose these lesions? As we said, the MRCP, the X-ray with oral contrast, and we talked about them. Then a very important step, which is what's called the diagnostic peritoneal lavage, DPL. And I'm sure that this DPL is very prevalent in the adult trauma services, but in fact, we are not using it in the pediatric age groups. We are not using the diagnostic peritoneal lavage tool of investigations to diagnose cases of intra-abdominal injuries in children, but it can be of value in the trauma settings in adults. But as I told you, the pancreas and the duodenum are retroperitoneal organs. They may be severely injured, but they may not be revealed inside the peritoneum. So you may have a negative DBL, but this doesn't mean that you don't have a pancreatic or duodenal injuries. Then we come to the important and what I call it the modality that everybody is interested to talk about, which is the laparoscopy. In general, is laparoscopy of value in trauma patients? Yes, but with limitations in the treatment aspect or treatment arm. While using the laparoscopy in certain situations may be important modality of diagnosis, and this can help to decrease the incidence of negative explorations up to 90% decrease in the negative explorations. So the use of laparoscopy in the trauma diagnosis and management is a promising field that we should use or try to use, but with certain precautions that we can explain or for you later, inshallah, in our discussion, if we have time. But I would like to say that laparoscopy had a role in diagnosing cases of trauma, especially the abdominal trauma, and you should consider. But of course, if you don't have the skill to manage the traumatic cases using laparoscopy, you should not use it, and you have to convert very soon and use the open techniques, because if you struggle with laparoscopy without moving, you may end with a disastrous results and complications in your patients. And of course, the last way of confirming the diagnosis and managing these cases is the surgical exploration. Next. Sometimes you don't know and you are not sure after all this diagnostic algorithm, and so you may resort to exploration in certain scenarios and certain situations. If you don't have the available investigations or the tools that I described, or the results of these investigations are not giving you the answer, but you are facing with a patient who is not doing well. I mean, you have very low or very minimal symptoms and signs or imaging findings, but the patient is not doing well. The patient is deteriorating very rapidly. So if you have a traumatic patient who is fitting these criteria, you have to go and do either laparoscopy if you have the skill and you have the instrument that you can use, or you have to go and do exploration. So don't hesitate to go and explore patients, because your main goal here is to save life of these patients. And again, I repeat that you have to consider your setting and situation to be able to take the right decision for your patients. Don't take the textbook decisions or textbook guidelines, because this is very important concept. Guidelines is no more than guides. It is not you. It is your responsibility, by the way. The people who put the guidelines are not responsible for managing your cases. You as a surgeon is the one responsible for your decisions. It's not the guidelines that says you do this or not do this. Because if there is the patient succumb or the patient died, you cannot say that the guidelines say like that. You are the one who is responsible. So that's why medicine is a wise, the doctor is a wise man. The wisdom is your most important tool in managing or in dealing with all conditions in medicine, not only traumatic situations. Next case, next slide, please. We will come to the management options. Next, please. Okay, as I told you, what is the main important question that you have to answer? The duodenum is perforated or not? If the duodenum is perforated, these patients need to be operated. No place for non-operative management for a patient with duodenal injury with a perforation. The only indications for conservative treatments in cases of duodenal injuries is what's called duodenal hematoma. Duodenal hematoma is a hematoma that occur in the wall of the duodenum. Patients will present with ultrasound findings or CT scan findings suggestive of a grade 1 or 2 injuries of the duodenum with thickening of the duodenal wall. Patients may present with an gastric outlet obstruction because of the hematoma. Patients may present with jaundice because of the presence of the duodenal hematoma that is involving the second part of the duodenum and compressing the common bile duct, or even pancreatitis if it is compressing and obstructing the pancreatic duct. Conservative treatment is the standard of care for duodenal hematoma. But if the obstruction or the hematoma symptoms persist beyond 14 days, you have to intervene. And the intervention is one of 3 ways, actually. Either intervention radiology, drainage of the hematoma, laparoscopic assisted drainage of the duodenal hematoma, or of course, an open surgery to drain these hematomas. So the standard of care of the hematoma, duodenal hematoma, is conservative treatment. If the symptoms of or due to the duodenal hematoma persists beyond 14 days, 2 weeks, you have to intervene. Intervention is either drainage, interventional radiology, laparoscopy, or open surgery. Next. As I told you, the non-operative management strategy is an evolving concept in the management of traumatic patients in the modern era. But what factors or prerequisites that you should have to adopt this strategy, the non-operative management strategy? As I told you, you should have a blood transfusion bank that supply you with the whole blood and the blood products 24 hours, 36, 5 days in the year. So you should have a blood bank and the transfusion service that is suitable for you to manage the fluctuating situation of the patients you are treating with a non-operative management. Number 2, you should have a good intervention radiology service, because one of the important pillars of the non-operative management is the angioembolization that your intervention radiology colleagues is going to do. Many of the bleeding that occurs in the liver, in the spleen, or in the kidneys, or in the pelvis can be controlled by angioembolization. And of course, if we talk about the angioembolization and its situations, when to use and when not to use, general angioembolizations or selective angioembolization will take the whole night. But if you don't have a service that can help you to do angioembolizations to control a continuous bleeding that occurs due to the trauma in these patients, so most probably your non-operative treatment or non-operative management or your NOM strategy will fail. So this is very important. As I described for you as well, the endoscopic service and the possibility of doing ERSP and stenting of the common bile duct, the pancreatic duct, or the disrupted or the transected main pancreatic duct is an important prerequisite for you if you want to do a non-operative management. And of course, external drainage through percutaneous pigtails is done by the interventional radiologist, or even the internal drainage by using an endoscopy, which is called the endoscopic gastrocystostomy, which now is prevailing, especially with the presence of the stents. That's you can do incision of all of you are aware of the cystogastrostomy in management of cases of pseudopancreatic cysts. You can do it endoscopically through the endoscopes. You do incisions in the posterior wall of the stomachs. You go inside the pseudocyst, and you can put a stent that can keep this incision open, and this can help you to deal with these cases. So endoscopic management of either in the acute settings or in the late sequelae afterwards and the complications of this trauma, you need to have a good endoscopic service to help you to manage these patients without doing operations. Next, please. In the extrahepatic biliary radical injuries, if you have injuries to the gallbladder, the solution is very straightforward: cholecystectomy. If you have ductal injuries, so the situation will depend on the general situation of the patients, the need for urgent laparotomy, backing, drainage, or stentings. All these modalities can be applied to the different scenarios of the traumatic injuries of the bile duct branches or bile duct injuries, the hepatic ducts or the common bile ducts. Next, please. Because you are in Aswan, so I found these pictures nice. Now يعني if you يعني لو انتوا يعني ما زهقتوش اقدر ان انا هنتكلم بقى دلوقتي على if you are going to do exploration for these patients, how are you going to manage, and what are the maneuvers that you should know to help you to identify the lesions, and what are the options for repairing or reconstructing or staging the treatment for these cases. هتحبوا نخش بقى in details في ده ولا دكتور ابراهيم؟ الو دكتور ابراهيم.
اتفضل يا دكتور اسامه، اتفضل.
نكمل ولا ايه الاخبار؟
اتفضل ايوه فندم حضرتك.
طيب ماشي، ممكن نتعرض تاني دكتور؟ هو احنا عندنا دكتور عزام منور يعني. طيب all of you are aware of this anatomical findings or anatomical elements in this area. So next, please, we can go to the next slide. Yeah. One of the most important maneuvers that you should know and do if you are going to manage cases of pancreatic duodenal injuries is the Kocher method. And all of you are aware of this, because by doing Kocherization of the duodenum, you will be able to expose the different parts of the duodenum and the head of the pancreas. So it's very important to know how to do Kocherization of the duodenum, mobilizations of the right hepatic flexures, and other maneuvers I will explain to you But cochlearization of the duodenum and extended cochlearization is an important step, because the success of managing these cases depends on an adequate exposure of these organs. So without doing cochlearization, without mobilization of the column from lateral to medial, you will not be able to identify the area. You will not be able to assess the injuries in the different parts of the duodenum. Don't forget, you have 4 duodenal parts: the first part, second part, third part, and fourth part, and you should examine and assess all of them. You have the head of the pancreas, you have the pancreatic ducts, and you have the body and tail of the pancreas. So the first maneuver is cochlearization, or cochlear maneuver, or extended cochlear maneuver, depends on the extent of mobilization of the duodenum that you have to do. And cochlearization is not only important for exposure of this area, but as well an adequate management, for example, resection and anastomosis, doing either primary repair or resection and anastomosis of the duodenum should be done without tension. To achieve this, you should have a good mobilization of your duodenum by the cochlearization or by the cochlear maneuver. So this is the first maneuver that you should know: cochlearization and extended cochlearization. Sometimes, in some situations, you can do a reversed cochlearization. That means you start from the pancreas from the left to the right, rather than from the right to the left, especially if you have a very big tumors in this area. Next, please. Next, please. Of course, after you do cochlearization, you have to insinuate your fingers behind the neck of the pancreas and examine and assess the head and the body of the pancreas for the presence of lesions, contusions, disruptions. And this is very important. So after cochlearization, you can put your fingers behind the head of the pancreas to assess the head of the pancreas and the body of the pancreas. Next, please. This is another maneuver that you should be aware of, which is an extended form of the cochlearization. You should do mobilization of the right hepatic flexure. You should do cochlearization of the duodenum. And next, please. And after that, you should incise the peritoneum, in the posterior peritoneum, below or inferior to the pancreas, to be able to go to the retroperitoneum in this area. So the subhepatic inferior vena cava will be accessed or exposed this way, as well as the head and the body of the pancreas. And the third and the fourth part of the duodenum will be exposed and assessed using this decathlon Prash maneuver that you should do or should know. And this is mobilization of these organs from the lateral to the medial aspects. So now you have the Kocher maneuver, the cattle Prash maneuver. You should know about it. Yes, next. And to assess the tail of the pancreas, you have to do another maneuver, which is called the Erd maneuver. The Erd maneuver, you mobilize the spleen from the left side, and by doing this, you will be able to mobilize, assess the spleen and its integrity, as well as the tail of the pancreas, and you see whether the tail of the pancreas is transected or injured or not. So another maneuver, which is mobilizing from the left to right, or from the left side to the medial side, is the Erd maneuver that you should do. And it is very important when you are doing surgery in this area, because as I told you, exposure is very important. Without good exposures, you will not do a good operation for this patient. Next, please. Another important maneuver from left to right is to take the organs on the left side, the colon and the and the spleen, and moving them as well medially. And you in the literature you will read about this as the Mattox maneuver. And if you do extended Mattox maneuvers, you are going to mobilize the left kidney from the left side to the medial aspects, and this will help you to identify the intra-abdominal aorta if you want to deal with any injury or any lesion in this area. So these maneuvers, the ERD, the Mattox, the Mattox, the Cattles, the Kocher, all these maneuvers can be helpful to expose this area, but not only in the pancreas and the duodenal injuries, but as well if you have other injuries in the colon, in the mesentery of the small intestine, or in the big vessel in the retroperitoneum. So these maneuvers is a basic maneuvers, is a basic surgical steps and skills that every trauma surgeons should know, because it will help you to expose the area so you can assess the lesion, you can assess the degree on the severity of injury, and you can determine the type of operation that you need to do. Next, please. So now you identified, or you have an injury in the duodenum. What are you going to do? Next, please. This diagrammatic slide shows you a way to do a primary repair of the duodenum and then put a loop of jejunum. So you are doing a jejunal patch or a jejunal serosal patch on either a primary repair of the duodenal injury, or even if you are not able to do a closure of the duodenal injuries, you can stitch or suture the loop of jejunum to the area of disruption or perforation of the duodenum, and this is what is known as a serosal jejunal patch in repairing duodenal injuries. So this is one way of dealing with a perforation or a lesion in this area. Of course, you have to remember, very important now, that the grades of duodenal injuries 2, 3, and 4 or 5 is a very important determining factors for what type of surgery are you going to do for these patients. Are you going to do a primary repair, suturing, and then you have an adjunct for this primary repair? Or you are not able, and this occurs in the grade 2 duodenal injuries, if the injury or the perforation involved less than 50% of the circumference of the duodenum. If it is more, so you may not be able to do a primary repair or suturing of the duodenum. So you have to do resection anastomosis for these lesions, rather than just repair or suturing of the duodenum. And if you following the literature about duodenal surgery, you will try, or you will find that there are what's called adjuncts for these two procedures. I mean, the main two basic ways of managing duodenal perforation or injuries is either primary repair or resection anastomosis. And in sometimes in some scenarios and some patients, you need to add some procedures to help you to avoid complications, especially duodenal leakage, because all of you as surgeons are aware of the fact that duodenum, when you open the duodenum, it's very difficult situation. It's a nightmare because of the leakage, and the duodenal fistula, if it occurs, it will be a disastrous and a very big complications, and it will lead to a morbidity and even mortality for those patients. So what are the adjuncts that you can use in cases of duodenal injuries, in addition to the primary repair or the resection anastomosis? Next slide, please. Next slide. Yeah, here what we call the pyloric exclusion. What do you mean by pyloric exclusion? In fact, we mean that to help healing of the duodenum that we repaired, we exclude the food passage from its normal way from the stomach and the duodenum by closing the pylorus. I can understand that you may feel that it is a strange principle, but in fact, this was very prevailing, but not in the modern era, where closure of the pylorus, what is called the pyloric exclusion, and it occurred or it's done through a gastrostomy. You open the anterior wall of the stomach, you close the pylorus from inside, and do gastrojejunostomy without truncal vagotomy. What happens is that those patients have a continuity of their gastrointestinal tract through the gastrojejunostomy, and after 1 or 2 months, the pylorus will reopen again. And at that time, the duodenum had healed. So the pyloric exclusion is an adjunct for primary repair or resection and stenosis of the duodenum in a trial to decrease the incidence of leakage and fistula formation in the duodenum. Sometimes, to enhance or increase or shorten the time for pyloric opening, we have what's called the Cali variant. Cali variant is a variant of pyloric exclusion where you pass a nasogastric tube to the pylorus and then close the pylorus around this nasogastric tube. And after some times, you remove these nasogastric tubes, so you decrease or shorten the period of time that this pylorus needs to open, and then the pylorus open and the gastrojejunostomy will not be functional anymore. And by this way, you avoided the occurrence of leakage and the morbidity of the biliary or duodenal fistula. A high output fistula is very difficult to manage, and it can lead to disasters for your patients. In fact, the pyloric exclusion as an adjunct for managing these duodenal injuries now is going out of fashion, because many of the studies had shown that just doing the repair of the duodenum without or with pyloric exclusion, the results or the outcome are the same. So many surgeons now are not keen to do pyloric exclusions in cases of repaired duodenal injuries. Next, please. Next, please. This is an example of duodenal resection and anastomosis that can be used to deal with the grade 2 duodenal injuries, as I explained to you before, with or without adjuncts to avoid the leakage and problems of the duodenal fistula. Next, please. Next, please. Another term, yes. Another term that you may be hearing about or know about, what is meant by duodenal diverticulization. In fact, it is a way of staging the management of complex duodenal injuries. The concept is very straightforward. You convert the duodenum, especially the second part of the duodenum, into a diverticulum that is not draining either the pancreatic, the bile, or the food. That means you take all these secretions, the food, through gastrojejunostomy. So in the diverticulization, you do antrectomy, gastrojejunostomy, and you drain the bile ducts and the bile secretions away from the duodenum. So you converted the duodenum from a receptacle of the pancreatic the bile and the food into a diverticulum that is not receiving any of these things. And so this can help you, or this can help these duodenums to heal without the complication that can occur. So duodenal diverticulization is a temporary or a staging procedures that can be done to drain the duodenum and to drain the food from the duodenum through the gastrogenostomy. And this can help as well to healing of the duodenum and help us to manage complex duodenal injuries using the concept of duodenal diverticulization. Next, please. Another example of how to do duodenal diverticulization. So it is a variation of the main theme, is making the duodenum as a diverticulum that is not receiving any of the intestinal secretions that it should receive. Next, please. Then we come to the pancreatic injury management. Next, please. Next, please. As we said, برضو عشان يعني ألخص لكم القصة هنا في البنكرياتيك injuries. As we said before, the main determinant for the way of managing cases of pancreatic injuries is the grade of injury. We have grade 1, grade 2, where we have contusions, we have disruptions of the pancreatic glands. Then we have grade 3, where there is a transection of the pancreatic ducts, mainly at the tail of the pancreas. Then grade 4, where the injury is concentrated or is found on the head of the pancreas. And grade 5, where we have post pancreatic and duodenal injuries. In fact, to summarize, is there a rule for non-operative management for cases of pancreatic injuries? Yes. In grade 1, in grade 2, in grade 4 and 5, there is a rule for non-operative management of these cases. The best management for grade 3, where you have a transection of the main pancreatic ducts at the level between the body and tail, the treatment is operative, and the most convenient treatment and the most efficient treatment in these situations is distal pancreatectomy with or without splenic or spleen preservation. Of course, in children, preserving the spleen is a very important concept because, as you know, below 10 years of age, the immune system of the patients is dependent on the presence of the spleen. Splenectomy will increase what's called the fulminant post-splenectomy sepsis in children, and this mandates that you should preserve the spleen if you do a distal pancreatectomy for a child. As you know, the methods of preserving the spleen in general, if you in trauma and in oncology situations, for example, is two types of spleen preservation: the Kimura type and the Warshaw type of preservation of the spleen. Kimura is you preserving the spleen with its main blood supply, the splenic artery and the splenic vein. Where the Warshaw technique, you preserve the spleen with division of its main blood supply and leaving the spleen dependent on the short gastrics and the left gastroepiploic vessels. So in children, you should persist or insist to preserve the spleen if you are going to do distal pancreatectomy for those patients. Of course, you can do another types of resections for the spleen if you have injury in the body and disruption and disconnection of the main pancreatic duct in the body of the spleen, of the pancreas. You can do central resection of central part of the pancreas and doing pancreatic jejunostomy for the distal part of the pancreas. So a distal or a central pancreatectomy can be a strategy for managing lesions in the body of the pancreas if you are in need to resect part of the pancreas. And why we are insisting on doing central pancreatectomy in some patients? Actually, the long-term exocrine and endocrine function after resection of the pancreas is not well studied and it's not well known. So incidence of exocrine dysfunction and incidence of endocrine dysfunctions, which means diabetes, mellitus development in patients who sustain pancreatic injury, should be considered when you are dealing with patients with pancreatic injury. So as I said, the grade 3 pancreatic injury with disruption of the main duct of the pancreas, resecting the distal or the tail of the pancreas with preservation of the spleen. This is the grade 3 is the main indications or the main operative indications for patients with pancreatic injuries. For all other lesions, you may adopt a non-operative management, especially in children, because if you have pancreatic injuries at the level of the head of the pancreas, the only way if you go and try to resect or treat these lesions, the only way to deal with these lesions will be Weibull operation, pancreaticoduodenectomy. And as you know, pancreaticoduodenectomy is a very extensive type of operations, although in some types of complex pancreaticoduodenal injuries, the only way to deal with these lesions and their sequelae is pancreaticoduodenectomy. Next, please. As this slide shows, if you have injury at the level of the head of the pancreas with main pancreatic duct injury and duodenal injuries as well, what we call complex pancreaticoduodenal injuries, the only way to deal with this situation is pancreaticoduodenectomy. And as we said, it's not advisable to do pancreaticoduodenectomy or Webb's operations as a one-stage operation in the emergency setting. So you have to stage your operation. Staging the operation here means that you do a damage control type of surgery where you drain the bile duct, you drain the pancreas, and you debride the area, you pack the area in the first phase, and come in the next phase and do the reconstructive procedures. But a word of caution here is important. The time between the first phase, if you are going to stage the pancreaticoduodenectomy, the time between the first phase and the second phase should be a short one, because if you have a long duration between the first phase and the second phase, or the first stage and second stage, you will be faced with the problem of edema in the gastrointestinal tract, as well as the high possibility, because of this edema and because of the contamination of the area, the high incidence of anastomotic leakage if you did this staged operations, or if you did the reconstructive phase of the operations in a later date, or on a later date from the initial first phase. So you do the first phase, you control, you drain, you debride, and then the second phase should not be more than 48 hours from the first phase. This is a very important principle if you decided that the only way to deal with the complex lesion in this situation on this area is pancreaticoduodenectomy or Webb's operation. Next, please. Next, please. This slide is a slide that's showing the management algorithm of both the pancreatic and the duodenal injuries, both the non-operative managements and the operative managements, and how to do the indications and how to manage the operative part of managing these cases. Next, please. Next, please. This is the last 2 slides. So don't worry. I know that you may be now bored with a long lecture, but I tried to give
We
you a
all are
comprehensive.
very interested. We are very interested, Professor Osama.
Thank you very much. So the epilogue, if we want to say the last words in these situations, I can summarize the prologue or the introduction or the conceptual framework. But the last word is that. Next, please. Those types of injuries, you need to have a long-term follow-up for those patients. The story of the patients with duodenal or pancreatic injury will not finish or stop at the initial management algorithms that we applied for those patients. Late sequelae and complications are common, as for example, pseudopancreatic cysts, abscess formations in the abdomen, acute and recurrent pancreatitis, pancreatic fistula with all its problems and classifications, and of course, the endocrine and exocrine pancreatic deficiency. So the story of the patients with duodenal and pancreatic injury will not end at the point of emergency or acute management, but you have to anticipate the developments of complications, and you have to understand and to know how to manage these complications later on. So long-term follow-up for those patients is very important and is part of their global way of management or strategy for managing these cases. I hope that I tried to give you a review about the problem, about its different elements and difficulties, how to deal with, and of course I try to stress how to deal with if you are obliged to operate on those cases, how to manage, and what are the options available for you for managing different types or different grades of injuries when you explore these patients. Thank you very much. I hope that it was not a boring lecture. I know a lot of information and it was long, but I cannot or I could not make it less than this. Thank
احنا
you very
اللي
much.
متشكرين لحضرتك جدا يا فندم. متشكرين لحضرتك جدا يا فندم والله على الفيري illustrative سيشن، والحقيقه ان حضرتك حطيت قواعد للدايجنوزس والمانجمنت لموضوع يعني فيري هوت توبيك الحقيقه، وكتير من الزملاء واخواننا النواب والمهندسين المساعدين كانوا محتاجين ان هم يسمعوا من حضرتك، لان كمان التشايلد از نوت يانج ادلت، فالمانجمنت فيه مختلف شويه عن اللي ايه، عن التعامل مع الادلت. فاحنا شاكرين لحضرتك جدا يا دكتور اسامه بيه. لو في اي حد من حضراتكم له اي استفسار من دكتور اسامه، احنا سهرناه معانا بصراحه، بس لو في حد له اي سؤال او استفسار من دكتور اسامه يتفضل يسال، عشان نشكر الدكتور اسامه على تعبه معانا والله.
انا متشكر جدا على الفرصه دي، ويعني تحت امركم لو في اي استفسار عن اي حاجه، والواتساب بتاعي موجود لو بصيتوا بقى بعد كده على السلايدز وكده وعايزين اي explanation I'm happy to answer دلوقتي او بعد.
طيب في حد عندك يا دكتور نادر؟
لا شكرا جزيلا يا دكتور اسامه.
طيب
مفيش اي
في حد
حاجه.
اونلاين
كله كان واضح كده.
لا تمام، كله تمام، مفيش اي اسئله.
الزملاء
شكرا.
اونلاين على اليوتيوب او على الزوم، حد فيكم محتاج اي سؤال من استاذنا الدكتور اسامه؟ طيب احنا متشكرين لحضرتك جدا يا دكتور اسامه بيه، احنا هنبعت لحضرتك لينك التسجيل بتاع اللقاء على اليوتيوب عشان يبقى عند حضرتك،
تمام.
وان الزملاء برضو لو في اي حد له حاجه على الواتساب هيبعتوا لحضرتك، ويبقى في دايركت كونتاكت بين حضرتك وبين تلامذتك في اسوان وفي كل مصر.
تحت امرك.
واحنا شاكرين جدا 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 لحضرتك والله على التعب والمجهود ووجودك معانا والروح الطيبه في ان حضرتك يعني مديهم سبيس يقدروا يتواصلوا مع حضرتك دايركت، ويعني دي ونعم الاستاذ بجد يا دكتور اسامه. متشكرين لحضرتك
انا
جدا يا
متشكر جدا،
فندم.
انا متشكر جدا وسعيد بالتواصل معاكم، ويعني ان شاء الله يعني نتواصل دايما على خير باذن الله.
ان شاء الله يبقى في لقاءات جديده اخرى ان شاء الله
تحت امرك،
مع
تحت
حضرتك
امرك.
ان شاء الله. شكرا يا دكتور محمد
شكرا
نادر،
لحضرتك يا
شكرا يا
دكتور
استاذ
اسامه،
زهراء،
شكرا جزيلا
شكرا يا
لحضراتكم
استاذ
جميعا.
عزام،
شكرا لحضرتك.
شكرا يا فندم.
شكرا يا دكتور
اشوفك
اسامه.
قريب يا دكتور اسامه.
شكرا
مع
جزيلا،
السلامه.
اشوفكم على خير باذن
مع
الله.
السلامه. مع السلامه.
السلام عليكم.